Welcome to the Deep Dive. Ever wonder what keeps your body humming? Regulating everything from your energy levels to how you handle stress? Today, we're diving into the endocrine system, your body's amazing network of hormone-producing glands that act like tiny, incredibly precise messengers.
Think of it as the ultimate behind-the-scenes regulator. This system is absolutely fundamental for maintaining vital functions. I mean, everything from how we respond to injuries to guiding our growth, managing our metabolism, overseeing reproduction, and even keeping our fluid balance just right. It's quite a complex web with really far-reaching influence.
Exactly. And for this deep dive, we've got a chapter that really breaks down the anatomy and physiology of these crucial glands, along with, a clear overview of some common disorders that can throw things out of sync.
Right.
Our goal is to distill this information into the most important insights, giving you a solid understanding of how this system works and what can happen when it doesn't.
And at the heart of it all are two key concepts we'll be touching on frequently: glucose regulation, how the body manages its blood sugar, and hormonal regulation. That intricate dance of hormones controlling various bodily processes. Understanding these is really key to grasping endocrine health.
Okay, let's start with a fundamental principle. The negative feedback loop. It sounds a bit technical, but it's really the cornerstone of how the endocrine system maintains balance. Can you give us the simple version?
Yeah, absolutely. Imagine a thermostat controlling your home's temperature. When the room gets too hot, that's like a hormone level rising too high. The thermostat signals the furnace to turn off. That's the system reducing the stimulating hormones. Once the room cools down, hormone levels drop, the thermostat tells the furnace, okay, turn back on. The negative feedback loop in your body works very similarly. When a target gland releases too much hormone, that increased signals back to the control centers, mainly the hypothalamus and pituitary gland in the brain, to dial down the production of the hormones that were telling that target gland to work in the first place.
Got it.
It's a brilliant self-regulating mechanism.
That thermostat analogy makes it really clear. So it's all about checks and balances. Now, to figure out if the system is working correctly or what might be going wrong, there are various diagnostic tests. Seems like quite an arsenal of tools.
It is, yeah. We have tests that stimulate or suppress hormone release to see if the glands respond appropriately. There's the radioactive iodine uptake test, which gives us a picture of thyroid function. Blood tests like T3 and T4 levels and thyroid stimulating hormone, or TSH, are crucial. Imaging techniques like thyroid scans help visualize the gland, and sometimes a needle biopsy provides a cellular level of detail. For specific areas, we have the glycosylated hemoglobin, HbA1c, test for long-term blood sugar control, and a 24-hour urine test for vanillyl mandelic acid, VMA, which can help diagnose a specific adrenal gland issue.
Let's zoom in on these diagnostic tests, starting with the stimulation and suppression tests. What's the underlying logic there?
Well, think of it like this. If you suspect a gland isn't producing enough hormone that's hyperfunction, a stimulation test tries to give it a boost. We administer a substance that should normally make the gland release its hormone. Then we measure if the hormone levels actually go up. If they don't, it suggests the gland has a problem producing that hormone. It's like a car engine that won't rev even when you hit the gas. On the other hand, if we suspect a gland is overactive hyperfunction, a suppression test tries to apply the brakes. We give a substance that should normally tell the control center to reduce stimulation of that gland, leading to lower hormone levels. If the hormone levels don't decrease as expected,
then something's wrong.
Exactly. It means the normal braking system, that negative feedback loop we talked about, isn't working properly.
So one checks if the gland can work, and the other checks if it can be told to stop working. That's a great way to put it. Our source mentions the overnight dexamethasone suppression test. Is that a common example of a suppression test?
It is, yes. Dexamethasone is a synthetic steroid that mimics cortisol. In a healthy person, taking it should suppress the body's natural cortisol production. If cortisol levels don't suppress as expected, it can indicate a problem with the adrenal glands, like in Cushing syndrome, where there's excessive cortisol production.
Next up, the radioactive iodine uptake test. The radioactive part might sound a bit concerning. But how does it actually help assess the thyroid?
Well, what's clever about this test is that it uses a very small, safe amount of radioactive iodine. Remember, the thyroid gland needs iodine to make its hormones. The idea is to see how efficiently the thyroid is taking up this iodine from your bloodstream. You'll take the radioactive iodine, either orally or intravenously, and then we'll measure the radioactivity in your thyroid at a couple of points in time, typically a few hours after, and then again about 24 hours later.
And what do those measurements tell us about how the thyroid is working?
Well, normal uptake ranges vary a bit between labs, but generally we'd expect to see around 3 to 10% of the iodine taken up in the early hours.
Okay.
And maybe 5 to 30% at 24 hours. If the uptake is higher than normal, it often suggests hyperthyroidism, an overactive thyroid that's eagerly grabbing the iodine to make more hormone.
Right.
Interestingly, it can also be elevated if you're, say, deficient in iodine in your diet, or if your body is losing too much iodine. Conversely, if the uptake is lower than normal, it could indicate hypothyroidism, where your thyroid isn't producing enough hormone. Or it could mean you're taking medications that are blocking iodine uptake, like antithyroid drugs. It might also be seen in conditions like thyroiditis, inflammation of the thyroid, or in a severe form of hypothyroidism called myxedema.
Myxedema. Yeah. What exactly is that?
Myxedema is essentially a state of very low thyroid function. You see characteristic physical signs like facial swelling and very dry skin.
Got it. So it's like watching how hungry the thyroid gland is for its raw materials. Are there any situations where this test wouldn't be a good idea?
Absolutely. Because radioactive iodine can affect the developing thyroid gland of a fetus, this test is definitely contraindicated during pregnancy.
That's a really important point to remember. Okay, moving on to the T3 and T4 resin uptake tests. These are straightforward blood tests measuring thyroid hormone levels, right?
Precisely. These blood tests directly measure the total amounts of triiodothyronine, T3, and thyroxine, T4, in your blood. These are the two main hormones produced by the thyroid gland, and they're critical for regulating your metabolism. They also play a key role in that feedback loop, influencing the release of TSH from the pituitary gland.
And what are the typical ranges we might see for these, keeping in mind lab variations, of course?
Right. They do vary slightly, but generally total T3 might be around 70 to 205 nanograms per deciliter. Okay. Total T4 from 5 to 12 micrograms per deciliter. And free T4, that's the active form not bound to proteins, around 0.8 to 2.8 nanograms per deciliter.
So what do high or low levels of T3 and T4 suggest?
Well, high levels of T3 are often a strong indicator of hyperthyroidism. It's interesting to note that T3 levels tend to naturally decline as we age. They can also be lower in hypothyroidism. For T4, it's a more direct measure. High T4 levels usually point towards an overactive thyroid.
Hyperthyroidism.
Right. And low levels generally suggest an underactive thyroid or hypothyroidism.
Now, the TSH test seems really central to figuring out thyroid problems. How does that fit into the puzzle?
The thyroid-stimulating hormone, or TSH test, is another blood test. It's particularly useful in helping us determine if hypothyroidism, that underactive thyroid, is originating in the thyroid gland itself. We call this primary hypothyroidism.
Okay, primary meaning the thyroid is the issue.
Exactly. Think back to the feedback loop. If the thyroid isn't making enough T3 and T4, the pituitary senses this and tries to stimulate the thyroid by releasing more TSH.
Like shouting louder.
Yeah, basically. So a high TSH level usually tells us that the problem is with the thyroid gland itself. The normal range for TSH is generally around 2 to 10 microinternational units per liter, again, with some lab variation.
And what if the TSH level is low? What does that tell us?
A low TSH level can suggest a couple of things. It might indicate hyperthyroidism, the thyroid's making too much T3 and T4, and these high levels are telling the pituitary to basically shut off the TSH supply.
Makes sense.
Or it can point to secondary hypothyroidism. In this case, the problem isn't with the thyroid itself, but with the pituitary gland not producing enough TSH to stimulate the thyroid in the first place.
Ah, okay.
So the thyroid isn't working well because it's not getting the signal.
That distinction between primary and secondary hypothyroidism based on TSH levels is really helpful. Okay, next up is the thyroid scan. How is that different from just measuring iodine uptake?
Well, the thyroid scan also uses a small amount of radioactive material, either iodine or technetium, but the goal here is to actually create an image of the thyroid gland.
Ah, picture.
Exactly. This allows us to visualize its size, shape, and any areas of increased or decreased activity. It can help identify nodules, those are lumps or growths within the thyroid or other structural abnormalities.
Okay.
After you receive the radioactive isotope, a special scanner detects the radiation emitted by the thyroid gland, and it generates that picture.
So we can actually see what's going on inside the gland, not just measure its overall activity. What kind of preparation is needed for a thyroid scan?
First, it's important to reassure you that the radioactive dose is very low, very safe.
Okay.
We would need to know if you've recently had any imaging studies using contrast agents, as those can interfere.
Right. Your doctor will likely give specific instructions about stopping any medications containing iodine, usually about 2 weeks beforehand, because that can affect the uptake.
Makes sense.
They might also advise holding thyroid medication. And of course, we need to know about any iodine allergies.
Crucial.
You'll usually be asked not to eat or drink after midnight before the scan. If radioactive iodine is given orally, you might need to fast for an extra 45 minutes after swallowing it, and the scan might be done 24 hours later.
Okay.
If technetium is used, it's usually given intravenously about 30 minutes before the scan itself. And just like the uptake test, pregnancy and iodine allergy are contraindications.
Lots to consider before that test. What about a needle aspiration of thyroid tissue? That sounds like a more direct way to get information.
It is. A needle aspiration or fine needle aspiration biopsy is a minimally invasive procedure. A very thin needle is inserted into the thyroid gland to collect a small sample of cells.
This sample is then sent to a lab for cytological examination, meaning it's looked at under a microscope to identify the types of cells present.
Okay.
This is often done to evaluate thyroid nodules and determine if they are benign, which is non-cancerous, or malignant, meaning cancerous.
And the prep.
The great thing is, usually no specific preparation is needed beforehand. Afterwards, we just apply a little light pressure to the site where the needle went in.
That seems relatively straightforward. Now let's switch gears and talk about the glycosylated hemoglobin test, or HbA1c. We know that's a key marker for diabetes management. How does it work?
Right. The HbA1c test provides a really useful look at your average blood glucose control over the past, say, 3 to 4 months.
That's a long view.
Exactly. It works because glucose, the sugar in your blood, can attach itself to hemoglobin, that's the protein in your red blood cells carrying oxygen. The higher your average blood glucose levels have been over time, the more glucose gets attached to the hemoglobin. Since red blood cells live for about 3 months,
Right.
the HbA1c test essentially gives us a weighted average of your blood sugar levels during that period.
So a higher HbA1c means my average blood sugar has been higher.
Exactly. In individuals with diabetes mellitus, that's the condition where the body either doesn't make enough insulin or can't use it effectively, leading to hyperglycemia or high blood sugar.
Right.
The HbA1c level is typically elevated. One of the advantages is you don't need to fast beforehand. A normal level is generally considered between 4.0% and 6.0%.
Okay.
Our source mentions a correlation with estimated average glucose, or EAG, which translates the A1C percentage into a daily average blood sugar number, though we don't have the specific chart here.
Got it.
But ultimately, a consistently high HbA1c level is a strong indicator of poor glycemic control, meaning blood sugar hasn't been well managed.
That makes sense as a longer-term monitoring tool. Finally, the 24-hour urine collection for vanillymandelic acid, or VMA. What's that helping to diagnose?
This test is primarily used to help diagnose pheochromocytoma.
Pheochromocytoma.
Yeah, it's a bit of a mouthful. It's a rare type of tumor that usually develops in the adrenal medulla, the inner part of the adrenal glands.
Adrenal glands.
Right. These tumors can release excessive amounts of hormones called catecholamines, like epinephrine, adrenaline, and norepinephrine, or adrenaline.
Okay.
These play a big role in regulating heart rate and blood pressure. VMA is one of the breakdown products of these catecholamines.
Let's see.
So if someone has a pheochromocytoma that's pumping out a lot of catecholamines, they'll typically have elevated levels of VMA and other byproducts like metanephrine in their urine. Collecting all urine over 24 hours gives a more accurate picture of the total amount being produced.
Okay, that's a comprehensive look at the diagnostic tests. Now let's move on to disorders of the pituitary gland.
Right, the pituitary gland. Often called the master gland, it's small but mighty, sitting at the base of the brain and controlling many other endocrine glands.
So when things go wrong here...
It can have really widespread effects, yeah.
Right. And there are some general nursing considerations that apply to many pituitary disorders, especially regarding treatment.
Absolutely. Because the pituitary orchestrates so many other hormone-producing glands, a key part of managing these disorders often involves hormone replacement therapy.
Makes sense.
If the pituitary isn't making enough of a certain hormone, you'll likely need to take a synthetic version. It's incredibly important for you, the patient, to understand the signs and symptoms of both hypofunction, meaning too little hormone, and hyperfunction, meaning too much. This is especially crucial regarding your prescribed meds. Knowing when your dose might need adjustment, based on doctor's advice, of course, and recognizing when to seek medical intervention for signs of imbalance is vital for managing these conditions effectively and safely.
That's a really good foundation. Now, let's dive into specific pituitary disorders, starting with hyperpituitarism and the specific condition of acromegaly. What's the core problem in acromegaly?
Acromegaly results from the anterior pituitary gland producing too much growth hormone, GH, in adults.
In adults, specifically?
Yes, that's key. It's most often caused by a benign tumor on the pituitary. Because this happens after the growth plates in the long bones have fused, you don't get taller. Instead, you see a characteristic pattern of other changes.
Such as? What are some of the key physical signs and symptoms that might indicate acromegaly?
Some hallmarks include a noticeable enlargement of the hands and feet.
Okay.
You might also see a thickening and protrusion of the jaw, changes in facial features becoming more pronounced because GH affects connective tissues.
Right.
People can develop arthritic changes leading to joint pain, impingement syndromes where nerves get compressed.
Ouch.
Yeah. If the tumor presses on the optic nerve, visual disturbances can occur. Other common findings are excessive sweating, diaphoresis, oily, rough skin, and organomegaly, which is enlarged internal organs like the heart, liver, kidneys.
Wow.
Due to the hormonal imbalances, there's also higher risk for hypertension, atherosclerosis, cardiomegaly, enlarged heart, even heart failure. You might also see dysphagia, difficulty swallowing, a deepening voice, thickened tongue, narrowed airway leading to sleep apnea, hyperglycemia, high blood sugar, and increased risk of colon polyps and colon cancer.
That's a really wide range of potential effects. What are the main approaches to managing acromegaly?
The primary goal is to reduce the excess growth hormone production and its effects. This can involve pharmacological interventions, meds to suppress GH secretion or block its action. Radiation therapy to the pituitary, or a very precise form called stereotactic radiosurgery, might be used to shrink the tumor over time.
Right.
If the tumor is accessible and causing significant problems, a hypophysectomy surgical removal of the tumor is often preferred.
Okay.
Alongside addressing the cause, we also manage symptoms like pain relief for joints and emotional support for body image concerns, which can be significant.
Hypophysectomy sounds like a complex surgery. What are some of the key things to know about it?
It is a significant procedure, yeah. The goal is surgical removal of the pituitary tumor. The more common approach now is usually transsphenoidal surgery.
Through the nose.
Yeah, often using an endoscope through the nasal passages or sometimes under the upper lip. This route generally has fewer complications than the older method, a craniotomy, which is opening the skull.
Right.
But if a craniotomy is needed, potential complications could include increased intracranial pressure, bleeding, meningitis, that's an infection of the brain linings, and hypopituitarism, a deficiency in other pituitary hormones.
And what kind of care is involved before and after a hypophysectomy?
Before surgery, it's crucial to discuss what to expect, procedure, and recovery. We'd teach deep breathing and coughing exercises, but emphasize avoiding straining the surgical site.
Okay.
We review medications, which to continue, which to stop. After surgery, close monitoring of vital signs and neurological status is key.
Looking for changes.
Exactly. Monitoring for increased intracranial pressure, assessing vision, watching fluid balance, carefully avoiding overload and dehydration. We check electrolytes regularly. Corticosteroids are often given to replace hormones, plus analgesics for pain. Elevating the head of the bed helps reduce swelling, encourage deep breathing, but advise against coughing, sneezing, or straining during bowel movements increases pressure.
Got it.
We monitor the surgical dressing for drainage, and a key thing is watching for post-nasal drip or clear nasal drainage.
Why is that so important?
That could be cerebrospinal fluid, CSF, leaking from around the brain. We might even test clear drainage for glucose because CSF contains glucose.
Wow, okay.
And finally, reinforcing instructions for any post-op medications.
That's a very detailed picture. Let's move on to another pituitary disorder, diabetes insipidus. Despite the name diabetes, it's very different from diabetes mellitus, right?
Absolutely. Totally different. While both involve fluid balance issues, diabetes insipidus, or DI, is about a deficiency in the production or action of antidiuretic hormone, ADH.
Okay.
Also known as vasopressin. ADH tells the kidneys to reabsorb water. If ADH is low or the kidneys don't respond to it, the tubules fail to reabsorb enough water, leading to excretion of large volumes of very dilute urine. We distinguish between central DI, decreased ADH production, maybe from stroke, surgery, trauma, or sometimes it's idiopathic, meaning unknown cause, and nephrogenic DI, where the pituitary makes enough ADH, but the kidneys just don't respond to its signal.
So what are the main signs and symptoms that might suggest someone has diabetes insipidus?
The most striking symptom is polyuria producing huge amounts of dilute urine. This massive fluid loss leads to intense thirst, polydipsia, as the body tries to compensate. Despite drinking a lot, the urine stays dilute. You see inability to concentrate urine, low urinary specific gravity, normally 1.003 to 1.030. Other symptoms include dehydration signs like decreased skin turgor, dry mucous membranes, also fatigue, muscle pain, weakness, headaches, and postural hypotension.
Blood pressure dropping on standing up.
Exactly. Which can cause dizziness or fainting. Tachycardia, a fast heart rate, can also occur as the body tries to maintain pressure.
And how is diabetes insipidus typically managed?
The main focus is replacing lost fluids and, for central DI, replacing the deficient ADH, often with a medication called desmopressin. We closely monitor vital signs, neurological, and cardiovascular status. Ensure a safe environment due to that postural hypotension risk. Monitor electrolytes, watch for dehydration signs, maintain adequate fluid intake, IV hypotonic saline might be ordered, and meticulously track intake-output, daily weight, blood osmolality, and urine-specific gravity, looking for excessive output, weight loss, low specific gravity.
Now let's talk about the opposite problem. Syndrome of inappropriate antidiuretic hormone secretion, or SIADH. It sounds like the body is holding on to too much water.
That's exactly right. SIADH is characterized by hyperfunctioning of the posterior pituitary, leading to excessive release of ADH that isn't appropriate for the body's actual fluid needs.
What causes that?
Various things can trigger it. Trauma, stroke, certain cancers, especially lung or pancreas, some medications, even stress.
And what are the consequences of having too much ADH in the system?
Well, because ADH tells kidneys to conserve water, too much leads to increased intravascular volume, more fluid in the blood vessels. This can result in water intoxication where tissues get overloaded, and hyponatremia, dangerously low sodium due to dilution.
Low sodium. It's serious.
Very. The swelling of brain cells from excess water can cause cerebral edema, brain swelling, increasing the risk of seizures.
So what are the telltale signs and symptoms that might suggest SIADH?
You might see signs of fluid volume overload, bounding pulse, elevated blood pressure, unexplained weight gain, edema, or swelling. The hyponatremia can cause muscle weakness, confusion, lethargy, headache, and in severe cases, seizures. Lab tests would typically show decreased serum osmolality, blood is diluted, and elevated urine osmolality because the kidneys are holding water and concentrating urine. And despite the fluid retention, you might actually have decreased urine output.
And how is SIADH typically managed?
The main goals are to manage the excess fluid and gradually restore normal sodium balance. We monitor vitals and neurostatus closely, institute seizure precautions for safety. Watch carefully for fluid overload and hyponatremia signs. Elevating the head of the bed, but only slightly, maybe 10 degrees max, can sometimes help venous return and maybe decrease ADH release.
Interesting.
Meticulous intake-output tracking, daily weights. Monitoring fluid electrolyte balance, serum urine osmolality is crucial. Fluid intake is usually restricted. Diuretics might be prescribed to help get rid of excess fluid. Sometimes, if sodium is very low, IV fluids with sodium normal or hypertonic saline might be given, but very carefully to avoid overload. Loop diuretics might be used if serum sodium is at least 125 milli-UQL.
Okay, that gives us a solid understanding of pituitary disorders. Let's now shift our attention to the adrenal glands and the hormones they produce.
Right, the adrenal glands, those two small glands sitting on top of each kidney. They play a vital role producing hormones for stress response, metabolism, blood pressure, a lot. We'll start with Addison's disease, also known as adrenocortical insufficiency.
What's the fundamental problem in Addison's disease? What goes wrong with the adrenal glands?
Addison's disease is characterized by hyposecretion, not enough production, of hormones from the adrenal cortex, the outer layer. The key hormones affected are glucocorticoids, like cortisol, involved in stress response and glucose metabolism, and mineralocorticoids, mainly aldosterone, which regulates sodium, potassium, and blood pressure. We differentiate Addison's a direct problem with the adrenal cortex itself, often autoimmune, from secondary adrenal insufficiency caused by the pituitary not making enough ACTH, the hormone that stimulates the adrenal cortex. In secondary, aldosterone production is often spared because it's regulated differently.
And what are the key effects on the body when these adrenal hormones are deficient?
The loss of glucocorticoids, like cortisol, has several big consequences. Decreased blood vessel tone, reduced response to catecholamines, like adrenaline, important for blood pressure, especially under stress.
All right.
Glucocorticoid deficiency also impairs gluconeogenesis, the liver making glucose, which can lead to low blood sugar.
Okay.
The aldosterone deficiency also has crucial effects, mainly on fluid and electrolytes. Kidneys excrete too much sodium, retain too much potassium,
Leading to
dehydration, low blood pressure, hypotension, low sodium, hyponatremia, and hypopotassium, hyperkalemia.
So what are some of the telltale signs and symptoms we might see in someone with Addison's disease?
Well, our source refers to a table, but key signs include persistent fatigue, muscle weakness, unintentional weight loss, decreased appetite, and a characteristic hyperpigmentation, the darkening of the skin, especially in folds, scars, sun-exposed areas.
Interesting.
Due to low aldosterone, low blood pressure is common, maybe a craving for salty foods. GI issues like nausea, vomiting, diarrhea, abdominal pain can also occur.
And how is Addison's disease typically managed? What's the treatment approach?
The cornerstone is lifelong hormone replacement therapy. You'd need synthetic glucocorticoids like hydrocortisone or prednisone, and mineralocorticoids like fludrocortisone.
Lifelong.
Yes. Absolutely crucial to follow dosage instructions precisely. Never skip doses. You also need education on signs of both under-replacement Addison's symptoms returning and over-replacement, which can cause side effects similar to Cushing syndrome.
Yeah.
And it's vital to understand that during stress, illness, injury, surgery, your body needs more cortisol, so the dose will likely need a temporary increase following doctor's guidance.
Okay.
We also typically recommend a diet higher in protein and carbs because glucocorticoids can affect bone density, calcium, and vitamin D supplements might be advised. For some with mineralocorticoid deficiency, increasing dietary sodium might be needed. Important to avoid infections, manage stress, be cautious with OTC meds. Wearing a medical alert bracelet is essential. And report concerning signs promptly.
What about Addisonian crisis? That sounds like a very serious and acute situation.
It is indeed. A life-threatening condition from a sudden, severe lack of adrenal hormones, especially cortisol.
What triggers it?
Precipitated by stressors, acute illness, severe infection, trauma, surgery, or abruptly stopping corticosteroid meds in someone adrenally insufficient.
Okay.
Signs are severe. Sudden intense headache, severe pain in abdomen, legs, lower back, profound weakness, irritability, confusion, severe hypotension, potentially shock.
Wow. Immediate action.
Immediate intervention involves preparing to assist with IV administration of glucocorticoids like hydrocortisone. After the crisis resolves, they continue regular oral replacement therapy.
Now let's move to the opposite end of the spectrum, Cushing's syndrome, where there's an excess of adrenal hormones.
Right. Cushing syndrome results from the body being exposed to high levels of adrenocortical hormones, primarily glucocorticoids like cortisol, for a prolonged time.
What causes that excess?
Several causes. Could be adrenal gland tumors making too much cortisol, increased ACTH secretion from the pituitary overstimulating the adrenals, or, quite commonly, from long-term use of high-dose corticosteroid medications prescribed for other conditions like asthma or autoimmune disorders.
And what are some of the characteristic signs and symptoms that someone with Cushing syndrome might exhibit?
Again, the source refers to a table, but classic findings include skin becoming thin and fragile, easy bruising.
Okay.
You might see purple stretch marks, striae on the abdomen and thighs, muscle weakness and wasting, especially in arms and legs. People often develop a characteristic rounded moon face and a fatty deposit on the upper back, a buffalo hump. Hypertension and hyperglycemia are frequent. Excess cortisol suppresses the immune system, increasing infection susceptibility. Osteoporosis can occur. Women might get menstrual irregularities and increased facial body hair hirsutism. Mood swings and psychological changes are also common.
That's a pretty distinct constellation of symptoms. How is Cushing syndrome managed? Treatment options.
Management really depends on the underlying cause. We monitor vitals closely, especially BP, track intake output, weight, regular labs, WBC count, glucose, sodium, potassium, calcium. If it's an inoperable tumor, chemo might be considered. If a pituitary adenoma is causing high ACTH, radiation or hyperphysectomy might be options.
Right, remove the pituitary tumor.
Exactly. If it's an adrenal adenoma, then adrenalectomy, removing the affected adrenal gland, is often the treatment. If you have an adrenalectomy for Cushing's, you'll likely need lifelong glucocorticoid replacement.
Just like Addison's in a way.
Yes, and similar need to adjust dose during stress. Post-op, we watch for blood clots, as Cushing's increases risk. Providing support for body image concerns is important too, and again, advise wearing a medical alert bracelet.
Let's move on to primary hyperaldosteronism, also known as Conn's syndrome. What's the key hormonal imbalance here?
Conn's syndrome is characterized by hypersecretion, too much production, of the mineralocorticoid aldosterone from the adrenal cortex. Most common cause is a benign tumor, an adrenal adenoma on one adrenal gland. The excess aldosterone has big effects on fluid and electrolytes.
Well, so?
It leads to increased sodium and water retention by the kidneys, and at the same time causes kidneys to excrete more potassium. This combo results in hypertension and hyperkalemic alkalosis, low blood potassium with increased blood pH.
So what are the typical signs and symptoms that might point to Conn's syndrome?
You might have symptoms related to the low potassium, high sodium, and high blood pressure. Things like headache, fatigue, muscle weakness, cardiac dysrhythmias.
Irregular heartbeats.
Paresthesia, tingling numbness, tetany, muscle spasms, vision changes, sometimes glucose intolerance. Labs would show elevated serum aldosterone, low potassium, maybe high sodium.
And how is Conn's syndrome usually managed?
Treatment.
Management focuses on controlling the high BP and low potassium and addressing the cause. Monitor vitals, especially BP, watch for hypokalemia, hypernatremia, track intake output, urine-specific gravity. Also monitor for hyperkalemia, especially with kidney impairment or certain meds. Potassium supplements likely prescribed for hypokalemia, used cautiously with potassium-sparing diuretics. If caused by an adenoma, the primary treatment is usually adrenalectomy, removing the affected gland. And patient education about meds and potential complications of low potassium, high sodium is key.
Finally, in the realm of adrenal disorders, we have pheochromocytoma. We mentioned the VMA test for diagnosis. What else is important to know?
Pheochromocytoma is a relatively rare tumor, usually in the adrenal medulla. It produces and releases excessive catecholamines, epinephrine, and norepinephrine.
Those fight-or-flight hormones.
Exactly. Powerful hormones affecting heart rate and BP. Most are benign, but can be malignant. 24-hour urine VMA is key diagnostically. Primary treatment is surgical removal of the adrenal gland.
And if surgery is impossible?
Then management focuses on controlling symptoms from the excess catecholamines. It's crucial to be aware of potential complications, which can be serious due to cardiovascular effects.
Such as?
Hypertensive crisis with damage to eyes, retinopathy, and kidneys, nephropathy, heart enlargement, dysrhythmias, heart failure, heart attack.
Wow.
Increased blood clot risk, stroke. Severe cases can lead to death from shock, stroke, kidney failure, dysrhythmias, or even a dissecting aortic aneurysm.
Really serious potential outcomes. What are the signs and symptoms that might suggest someone has a pheochromocytoma?
Classic symptoms often include paroxysmal, sudden, unpredictable episodes or sustained hypertension, severe headaches, palpitations, flushing, profuse diaphoresis, sweating. Other symptoms can be chest or abdominal pain, nausea, vomiting, heat intolerance, nervousness, and hyperglycemia.
And how is pheochromocytoma typically managed? Nursing care involved?
Careful, continuous monitoring of vitals, especially BP, is essential. Vigilance for hypertensive crisis. Instruct to avoid activities triggering catecholamine release, increased abdominal pressure, vigorous exercise, deep abdominal palpation. Avoid certain meds like some decongestants and MAOIs. Antihypertensives, specifically alpha and beta blockers, are used to control BP. Calm, stress-free environment is important. If adrenalectomy is planned, careful pre-op prep, stabilizing BP is crucial. Post-op care involves monitoring vitals, intake output, report urine 30 ml/HR immediately. Daily weight, electrolytes, glucose monitored, watch for hemorrhage shock, especially first 24-48 hours, and signs of adrenal insufficiency if both glands affected. Pain management, encourage rest. Reinforce medical alert bracelet use.
What about that hypertensive crisis? Immediate actions?
Yes, the source highlights immediate actions. Semi-Fowler's position, notify RNP-HCP immediately, prepare oxygen, assist with slow IV and normal saline, assist with IV antihypertensives, frequent BP monitoring, watch for complications from the pressure surge.
That's a comprehensive overview of adrenal gland disorders. Let's now turn our attention to the thyroid gland and some common issues there.
Okay, the thyroid gland. Located in the front of the neck, butterfly-shaped. Crucial role in regulating metabolism via thyroid hormones. We'll start with hypothyroidism, decreased hormone production.
What's the fundamental problem in hypothyroidism and what happens to the body's functions?
Hypothyroidism is when the thyroid doesn't produce enough T3 and T4. This leads to a hypothyroid state, a significant decrease in the body's overall metabolic rate, affecting almost every system.
Okay.
In primary hypothyroidism, the problem is the thyroid gland itself. You typically see low T4 and elevated TSH.
Right, the pituitary trying to stimulate it.
Exactly. Secondary hypothyroidism is when the pituitary isn't producing enough TSH to stimulate a healthy thyroid.
And what are some of the common signs and symptoms that might suggest someone has hypothyroidism?
Again, source refers to a table, but key findings include persistent lethargy, fatigue, personality changes like irritability, mood swings, muscle weakness, aches, paresthesia, numbness, tingling, sometimes nervousness, fine hand tremors. Cold intolerance is classic.
Right.
Unexplained weight gain, dry skin hair, loss of body hair, bradycardia, slow heart rate, constipation. A generalized puffiness edema, often around eyes face, sometimes called myxedema.
Okay.
Forgetfulness, menstrual disturbances, hypertension, cardiac enlargement with heart failure risk, and sometimes an enlarged thyroid goiter, though not always present.
How is hypothyroidism typically treated and managed?
Primary treatment is thyroid hormone replacement therapy. Levothyroxine sodium is most common.
Okay.
Crucial to take it exactly as prescribed, consistently, usually same time each day on an empty stomach. Need to know signs of both under-replacement, hypothyroid symptoms persist, and over-replacement, which can cause hyperthyroid symptoms. Generally encourage a diet lower in calories, cholesterol, saturated fats, as metabolism is slow. Discuss benefits of regular moderate exercise, like walking.
We touched on myxedema earlier as a symptom. What is myxedema coma and why is it so concerning?
Myxedema coma is rare, but very serious. Potentially fatal. It's a complication of long-standing, severely untreated hypothyroidism, an extreme state of decreased metabolic function.
What triggers it?
Precipitated by acute illness, infection, stroke, rapid withdrawal of thyroid meds, anesthesia surgery, hypothermia, use of sedative opioids.
Signs.
Signs are severe. Significant hypotension, bradycardia, hypothermia, hypernatremia, hypoglycemia, generalized edema, respiratory failure, and ultimately coma.
Wow. Management?
Life support. Maintain airway, aspiration precautions, IV fluids, assist with IV levothyroxine and glucose, administer corticosteroids for potential adrenal insufficiency, monitor temp hourly, BP frequently, keep warm, monitor mental status, electrolytes, glucose.
Let's now discuss the opposite, hyperthyroidism. What's happening in this condition?
Hyperthyroidism is when the thyroid produces and secretes excessive T3 and T4, leading to a hypermetabolic state. Body processes speed up significantly.
Common cause?
Graves' disease is common. An autoimmune disorder can also cause a toxic diffuse goiter, enlarged thyroid making too much hormone. The clinical manifestations are called thyrotoxicosis.
And what do the hormone levels typically look like in hyperthyroidism?
Generally, elevated T3 and T4 in the blood. And due to that negative feedback, a low TSH level as the pituitary tries to reduce stimulation.
What are the telltale signs and symptoms that might make you suspect someone has hyperthyroidism?
Source has a table, but common findings include personality changes, irritability, agitation, anxiety, nervousness, fine hand tremors, heat intolerance, often with increased sweating.
Right.
Unintentional weight loss despite maybe increased appetite, smooth, soft skin hair, palpitations, tachycardia, sometimes atrial fibrillation, more frequent bowel movements or diarrhea, the characteristic protruding eyeballs, exophthalmos, diaphoresis, menstrual disturbances, hypertension, and often a goiter.
How is hyperthyroidism typically managed and treated?
Management aims to reduce production and effects of excess thyroid hormones. Ensure adequate rest, maybe sedatives for anxiety, cool, quiet environment for heat intolerance, daily weight monitoring.
Okay.
Recommend high-calorie diet for increased metabolism. Avoid stimulants like caffeine. Medications are key. Anti-thyroid drugs blocking hormone synthesis. Iodine preps inhibiting release. Beta blockers like propranolol for symptoms like rapid heart rate.
Right.
Radioactive iodine therapy is common. Oral dose destroys some thyroid cells. Sometimes subtotal thyroidectomy, surgical removal of part of the thyroid is needed.
What about the exophthalmos?
Elevate head of bed, low salt diet, artificial tears, dark glasses, maybe tape eyelids shut at night if needed. Important to allow discussion of body image concerns.
Just as hypothyroidism has myxedema and coma, hyperthyroidism has thyroid storm. What is that and what triggers it?
Thyroid storm or thyrotoxic crisis is an acute, severe, life-threatening exacerbation of hyperthyroidism. A sudden, extreme increase in thyroid hormone effects can be triggered in uncontrolled hyperthyroidism by manipulating the thyroid during surgery, sudden hormone release, severe infection, significant stress, trauma. Interestingly, meds might be given pre-op to prevent it.
What are the signs?
Dramatic signs: markedly elevated temperature, high fever, dangerously fast heart rate, tachycardia, high systolic BP, nausea, vomiting, diarrhea, significant agitation, tremors, anxiety, increased irritability, restlessness, confusion, potential seizures, delirium, coma.
And how is thyroid storm managed? Sounds like an emergency.
Absolutely a medical emergency.
Closing.
Reduce hormone levels effects, provide supportive care, maintain airway ventilation, administer antithyroid meds, sodium iodide, beta blockers, glucocorticoids.
Okay.
Continuous monitoring of vitals, cardiac rhythm. Manage fever with non-salicylate antipyretic. Salicylisis can increase free thyroid hormone. Cooling blankets might be used.
Let's delve a bit more into thyroidectomy, the surgical removal. What's involved in care before and after?
Before thyroidectomy, assess vitals, weight, electrolytes, blood glucose. Teach coughing, deep breathing, and how to support neck post-op. Meds might be given to prevent thyroid storm.
Okay.
After surgery, immediate priorities. Monitor for respiratory distress, swelling, bleeding can compress airway. Tracheotomy set, oxygen suction must be at bedside.
Crucial.
Limit talking initially. Assess for hoarseness, could indicate laryngeal nerve damage. Avoid neck flexion, stress on sutures. Monitor continuously for signs of laryngeal nerve damage. Obstruction, dysphonia, high-pitched voice, stridor, dysphagia, restlessness.
What else post-op?
Another critical concern, hypocalcemia and tetany due to potential parathyroid damage removal. Monitor for signs, cardiac dysrhythmias, carpopedal spasm, dysphagia, muscle abdominal cramps, numbness, tingling, face extremities, positive Schwarzschick's trousseau signs, visual disturbances, wheezing, dyspnea, seizures.
Treatment for tetany.
5-E calcium gluconate as prescribed. Also continue monitoring for thyroid storm post-op. Semi-Fowler's position helps reduce neck swelling. Monitor surgical site for edema, bleeding, check front and back of neck.
That's a lot to keep an eye on after a thyroid surgery. Let's now move on to disorders of the parathyroid glands.
Okay, the parathyroids. Usually 4 small glands on the back of the thyroid. They produce parathyroid hormone, PTH, essential for regulating blood calcium. We'll start with hypoparathyroidism, insufficient PTH.
What happens in hypoparathyroidism, and what are the consequences of low PTH?
Hypoparathyroidism is insufficient PTH production. Can happen after thyroidectomy if glands are damaged or removed.
Right.
Since PTH maintains blood calcium, deficiency leads to hypocalcemia, low calcium, and hyperphosphatemia, high phosphate.
And what are the typical signs and symptoms that might suggest hypoparathyroidism?
Numbness, tingling around mouth, fingertips, toes. Muscle cramp spasms, especially abdomen extremities. Positive Trousseau-Schwazdeck signs, clinical indicators of low calcium.
Okay.
More severe signs of overt tetany can occur. Bronchospasm, laryngospasm, airway spasms, carpopedal spasm, hands-feet spasms, dysphagia, photophobia, light sensitivity, cardiac dysrhythmias, even seizures.
How is hypoparathyroidism typically managed and treated?
Goal is to raise blood calcium, lower phosphate. Monitor vitals, watch for signs of hypocalcemia, hyperphosphatemia. Institute seizure precautions due to risk.
Diet.
High calcium, low phosphorus diet. Limit avoid milk, dairy, egg yolks, spinach, high in phosphorus. For acute tetany, IV calcium gluconate might be given.
Okay.
Vitamin D supplements often prescribed to increase calcium absorption. Synthetic PTH might be given. Phosphate binders help excrete phosphate via GI tract. Thiazide diuretics might be used cautiously with vitamin D to help kidneys retain calcium. And wear a medical alert bracelet.
Now, let's discuss the opposite, hyperparathyroidism. What happens when there's too much PTH?
Hyperparathyroidism is overproduction of PTH by one or more glands. This excessive PTH leads to increased calcium resorption from bones into blood, increased calcium absorption from intestines, increased reabsorption by kidneys, resulting in hypercalcemia, high blood calcium, and hypophosphatemia, low blood phosphate.
What are the typical signs and symptoms that might suggest hyperparathyroidism?
Fatigue, generalized weakness, bone pain tenderness, even bone deformities, fractures from calcium loss. Loss of appetite, nausea, vomiting, constipation, increased urination, polyuria, excessive thirst, polydipsia, and kidney stones due to increased calcium in urine.
And how is hyperparathyroidism typically managed and treated?
Focus is lowering elevated calcium, addressing underlying cause, often a benign tumor, adenoma. Monitor vitals, watch for hypercalcemia, hypophosphatemia. Encourage increased fluid intake, helps prevent kidney stones, dehydration.
Medications.
Furosemide diuretic can help lower calcium by increasing urine excretion. 4V normal saline for hydration calcium excretion. Phosphates might be used cautiously. Calcitonin decreases calcium release from bones, increases kidney excretion. Ivorobisphosphonates inhibit bone breakdown.
Okay.
Monitor calcium phosphorus levels regularly. If caused by a tumor, definitive treatment is usually parathyroidectomy, surgical removal. Encourage high fiber, moderate calcium diet. Emphasize exercise, avoid prolonged inactivity, worsens bone calcium loss.
Let's delve a little deeper into parathyroidectomy. Key things about this surgery and post-op care.
Parathyroidectomy is removal of one or more parathyroid glands, often done endoscopically, radio-guided, minimally invasive. Sometimes autotransplantation is done.
Autotransplantation.
Yeah, take a small piece of healthy parathyroid tissue, transplant it elsewhere, forearm, neck muscle, allows it to continue producing PTH.
Interesting. Pre-op.
Check calcium levels, provide education about procedure post-op care. Most important, monitor for hypocalcemia and tetany. Even with remaining transplanted tissue, it can take days to function properly if suppressed before surgery. So monitor calcium closely, watch for those low calcium signs. Initially, if autotransplant hasn't kicked in, might see temporary rise in calcium. Monitor surgical site for bleeding infection. Semi-Fowler's position usually recommended.
Okay, we've covered a lot about the individual endocrine glands. Now let's move on to a major area, diabetes mellitus.
Right, diabetes mellitus, a group of metabolic diseases characterized by hyperglycemia, high blood sugar, from defects in insulin secretion, action, or both.
Pancreas is key here.
Absolutely. Pancreas produces insulin and glucagon, which regulate blood glucose. Insulin helps glucose enter cells for energy. Glucagon raises blood glucose when low. They mainly influence carb metabolism, but indirectly affect fats proteins too.
So what's the fundamental problem in diabetes? What's wrong with insulin?
At its core, it's an absolute or relative insulin deficiency leading to hyperglycemia. Two main types. Type 1 is near absolute insulin deficiency.
Autoimmune.
Usually, yes. Immune system destroys insulin-producing beta cells in pancreas. People with type 1 need insulin to survive. Lack of insulin leads to fat breakdown for energy, producing ketones.
Ketonemia.
Right, which can cause dangerous metabolic acidosis. Type 2 is more complex. Relative lack of insulin or insulin resistance, cells don't respond well, or both.
Okay.
Usually still some insulin production in type 2, often enough to prevent fat protein breakdown, but not enough to regulate carbs and keep blood glucose normal.
Our source also mentions metabolic syndrome, Syndrome X. How does that link to diabetes?
Metabolic syndrome is a cluster of conditions often occurring together, significantly increasing risk for type 2 diabetes and cardiovascular disease.
What conditions?
Abdominal obesity, hyperglycemia, elevated but maybe not diabetic range yet, hypertension, high triglycerides, blood fat, and low HDL cholesterol. Good cholesterol. Recognizing it is important as a major risk factor.
So how is diabetes generally managed? Key components of a care plan.
Primary goals. Keep blood glucose near normal, prevent delay, long-term complications. It's multifaceted. First, regular monitoring. Self-monitoring, SMBG, with a glucometer, plus regular A1C tests for the long-term average.
Right.
Second, individualized diet plan. Considers weight, meds, activity, other health issues. Consistency and timing amount of carbs is key. Might follow ADA guidelines, use MyPlate, or carbohydrate counting, tracking carb grams per meal, good for intensive insulin therapy. Tailored to lifestyle, culture, socioeconomic factors.
Okay. What else?
Third, regular physical activity, extremely beneficial. Lowers glucose, helps weight loss, reduces cardiovascular risks, improves circulation muscle tone, lowers cholesterol, triglycerides, increases insulin sensitivity.
Exercise adjustments.
Dietary adjustments might be needed to prevent lows. Extra food during exercise, not deducted from meal plan. Avoid exercise if glucose 250 milligdl with ketones, type 1, until normalized. Exercise same time daily, ideally when meal glucose peaking, not insulin peak. Avoid injecting insulin into area about to be exercised heavily.
On fourth, medications.
Fourth, medications. Insulin is essential for type 1, may be needed for type 2, various types. Rapid, short, intermediate, long-acting, premixed.
Delivery methods.
Subcutaneous injection, syringe pen, insulin pumps. 40 in emergencies, regular insulin. Proper storage, crucial. Never alter doses without provider advice. Illness, infection, stress, increased glucose insulin needs. Don't withhold insulin without advice. Regular insulin U100 can be IV push infusion. Short duration, Lispro, Aspart, Glulicine, can be IV infusion in clinical settings.
Insulin therapy, while essential, can also have potential complications, right? What should people be aware of?
Yes, a few things. Local allergic reactions at injection site. Redness, swelling, tenderness, induration, hardness, wheal, raised itchy area, 1-2 hours after injection. More common early on. Cleaning skin helps.
Okay.
Insulin lipodystrophy. Changes in fatty tissue at injection site from repeated use lumps or depressions. Using human insulin helps prevent it. Crucial to rotate sites systematically within one area, abdomen, thighs. Avoid same spot more than once in 2-3 weeks. Injections 1.5 inches apart. Don't inject into affected sites. Absorption is erratic.
What about those morning high blood sugars?
Right. 2 phenomena. Dawn phenomena. Hyperglycemia on waking due to natural early morning release of hormones like growth hormone cortisol counteracting insulin. Treatment might be increasing evening insulin dose or changing timing.
And the other.
Samoji phenomenon or rebound effect. Normal high bedtime glucose, then hypoglycemia around 2-3 a.m. Too much insulin, not enough food. Body releases counter-regulatory hormones causing rebound hyperglycemia by 7 a.m.
Symptoms.
Might report early morning headaches, night sweats, nightmares from the nighttime low. Treatment often involves decreasing evening intermediate insulin or increasing bedtime snack, or both.
Let's talk a bit more about the different ways insulin can be administered. It's not just syringes anymore.
That's right. Syringes are still common. Insulin pens are convenient, portable. Specific guidelines exist for safely mixing insulins in a syringe if needed.
And pumps.
Insulin pumps are increasingly popular. Small computerized devices delivering continuous subcutaneous infusion of rapid short-acting insulin via a catheter under the skin, often abdomen, changed every 2-3 days.
How they work.
Delivers a continuous basal rate, background insulin, plus bolus doses before meals based on glucose, carbs, activity. Newer pumps integrate with continuous glucose monitors.
CGM.
Small sensor under skin measures glucose continuously, transmits to pump. Some advanced closed-loop systems can automatically adjust insulin based on CGM readings, hold 3-day supply, easily disconnected for bathing, etc.
What about pancreas transplants?
Less common option, usually for specific clients, often with simultaneous kidney transplant. Goal is to restore near-normal glucose regulation, potentially halt reverse complications. Major surgery requires lifelong immunosuppression.
Self-monitoring of blood glucose seems absolutely critical. Can you talk more about why it's so important and how it's done?
SMBG is indeed a cornerstone. Provides real-time info about your blood glucose. Essential for informed decisions about diet, exercise, meds within provider guidelines for good glycemic control.
How's it done?
Most common. Glucometer. Use lancet to prick fingertip, get blood drop, apply to test strip inserted in meter, displays level in seconds.
Alternative sites.
Some meters allow testing forearm, upper arm, abdomen, thigh, calf, but use finger pricks when glucose changing rapidly after eating exercise, or if suspecting hypoglycemia, as alternative sites lag behind. Especially important if neuropathy affects sensation.
Ensuring accuracy.
Use correct technique per manual, wash hands thoroughly, calibrate monitor if needed, check strip expiration, reread manual reassess technique if results seem off.
What about urine testing? We used to hear about testing urine for sugar. Still common.
Urine testing for glucose isn't reliable for routine monitoring anymore. Only shows when blood glucose has been very high, exceeding kidney threshold. Not real time, not sensitive enough for daily management.
But urine ketone testing.
Still important, yes, especially for type 1, sometimes type 2 during illness or high glucose. Ketones mean bodies breaking down fat for energy due to insufficient insulin. Can be early warning for DKA.
When to test for ketones?
During illness, cold, flu, whenever blood glucose persistently high, for example, 240 milligdl for 2 tests, or as provider instructs, simple OTC urine strips available.
Now let's move on to the acute immediate complications. We've touched on ketoacidosis and hypoglycemia, but let's delve deeper.
Okay. One of the most immediate dangers is hypoglycemia, low blood glucose, typically 70 mg/dL, but rapid drop from high can cause symptoms too.
Causes.
Too much insulin oral meds, too little food-skipped meals, more activity than usual without adjustment, alcohol without enough food. Crucial to always carry fast-acting simple carbs. Source lists: glucose tablet still, hard candy, sugar, honey syrup, fruit juice, regular soda, low-fat milk, saltines, graham crackers. If nothing specific available, eat any food, though high fat slows absorption.
Hypoglycemia unawareness.
Yes, some people frequent lows. Older adults, those on beta blockers, might lose early warning signs until dangerously low. Increases risk of severe hypoglycemia.
What are the symptoms of hypoglycemia and what's the recommended action?
Symptoms vary. Mild might be hunger, nervousness, palpitations, sweating, tremor. Moderate. Worsening symptoms may be confusion, irritability, blurred vision, weakness, slurred speech. Glucose often 40 mg/dL. Severe. Neuroglycopenic symptoms: insufficient glucose to brain, disorientation, seizures, loss of consciousness, coma. Glucose often 20 mg/dL.
Priority action, the 15-15 rule.
Right. Check glucose if possible. If 70 mg/dL or symptomatic and no meter, assume hypo. Give 15 g fast-acting carb, for example, 12-cup juice, glucose gel. Recheck glucose in 15 months. If still 70, repeat 15 g carb. Recheck in 15 months. Repeat if needed.
If no improvement.
If no improvement after 2-3 times or condition worsens, contact provider, seek emergency help immediately. Once glucose normal, ensure adequate meal snack with protein fat if next meal 1 hour away to prevent another drop. Educate patient family on signs treatment.
What about severe hypoglycemia and unconsciousness?
Do not give oral food fluids, aspiration risk. Administer glucagon injection, subcutaneous intramuscular. Family friends should be trained. In hospital ED, FAR-V injection of 25-50 milliliters of 50% dextrose might be given.
Let's now focus on diabetic ketoacidosis, DKA. Key features.
DKA, acute, serious, life-threatening. Uncontrolled hyperglycemia, ketones, metabolic acidosis, most common in type 1, can occur in type 2.
Onset triggers.
Often sudden onset. Triggered by missed insulin, illness, infection, untreated, undiagnosed diabetes.
Manifestations.
Ketosis signs: Kussmaul's, respirations, deep rapid breathing, fruity breath odor, acetone, nausea, abdominal pain, dehydration, electrolyte loss signs, polyuria, then decreased urine, polydipsia, weight loss, dry skin, sunken eyes, lethargy, coma.
Lab findings.
Glucose 300 mg/dL, positive serum ketones, pH 7.35, acidosis, HCO3 15 MEQL, sodium variable. Potassium initially normal high, acidosis shift, drops later with treatment loss, elevated BUN creatinine, dehydration, positive urine ketones.
Sounds dangerous. How is DKA managed in hospital? Priority interventions.
Prompt aggressive treatment in ICU usually.
Priority.
Airway management, oxygen PRN, establish large bore IV access, begin fluid resuscitation, 0.9% or 0.45% NS, depending on status. Initial bolus, then continuous infusion. Monitor for fluid overload, especially about older renal heart issues. Monitor urine output.
Glucose insulin.
Check glucose hourly. When glucose 250-300 mg/dL, change YB fluid to one with dextrose, prevents rapid drop cerebral edema. Administer regular insulin IV, bolus, then continuous infusion pump.
Electrolytes.
Correct imbalances. Monitor potassium very closely, drops rapidly with treatment. Cardiac monitoring due to potassium risks. Watch for increased intracranial pressure, cerebral edema risk if glucose drops too fast.
And the other major acute complication, hyperosmolar hyperglycemic syndrome, HHS. How does it compare to DKA?
HHS, extreme hyperglycemia, severe dehydration, but typically no significant ketoacidosis. More common in type 2, especially older adults, often with illness reducing fluid intake. Key difference: absence of significant ketone acidosis. Usually enough insulin to prevent fat breakdown, but not enough to prevent severe hyperglycemia. Onset typically more gradual than DKA.
Manifestation slabs.
Primary: severe dehydration, altered CNS function, neurological symptoms, confusion to coma, due to extreme hyperosmolarity. Dehydration signs similar to DKA. Labs: glucose 600 mg/dL, often much higher. Osmolality 350 ml, negative trace ketones. pH 7.4, HCO3 20 MEQL, potassium normalo. Elevated BN creatinine.
So the absence of ketone acidosis is the major distinguishing factor. How is HHS managed?
Similar to DKA.
Right.
Aggressive fluid replacement priority, electrolyte correction, ISS, potassium, IV, insulin. Fluid replacement needs careful management in older adult heart failure risk. Insulin less critical initially than DKA. Rehydration alone often lowers glucose significantly. Plus monitoring vital.
We've covered acute complications. Now let's turn to the long-term, chronic complications from diabetes over time.
Right. Chronic hyperglycemia over years damages small blood vessels, microvascular, and nerves, neuropathy. leads to serious complications. One is diabetic retinopathy, damage to retinal blood vessels in the eye.
Effects.
Impaired circulation, microaneurysms, hemorrhages, abnormal new vessel growth, neovascularization, can cause permanent vision changes, blindness. Managing SMB insulin injections becomes hard with vision loss.
Symptoms.
Early stages might be asymptomatic. Later, blurred vision, floaters, vision loss, macular edema, swelling in central retina causes blurred vision. Management, regular ophthalmologist exams, strict glycemic control, manage hypertension, laser injections for advanced stages.
Another major concern. Kidneys, diabetic nephropathy.
Correct. Progressive decline in kidney function from damage to glomeruli, filtering units. Early sign, microalbuminuria, small amounts of albumin protein in urine.
Later symptoms.
Thirst, fatigue, anemia, weight loss, malnutrition signs, frequent UTIs, neurogenic bladder signs, nerve damage affecting bladder.
Management.
Early prevention. Hypertension, glucose control. Monitor vitals, IO, BUN creatinine, urine albumin. Restrict dietary protein, sodium, potassium as prescribed. Avoid nephrotoxic meds. Prepare for dialysis, kidney transplant, pancreas transplant if planned.
And then there's the widespread impact on the nervous system. Diabetic neuropathy.
Nerve damage from chronic high blood sugar. Common, potentially debilitating complications. Non-healing foot ulcers, gastroparesis, delayed stomach emptying, erectile dysfunction.
Classification.
Focal mononeuropathy, single nerve group, example, cranial nerves, hypotide causing diplopia, double vision. Sensory peripheral, stall nerves, lower extremities, common, stocking glove, autonomic, nerves controlling involuntary function.
I'm a heart attack.
Varies by organ, cardiovascular, abnormal HR response, orthostatic hypotension. Pupillary, no dilation to dim light. Gastric, gastroparesis, delayed emptying. Urinary, neurogenic bladder. Skin, decreased sweating. Adrenal, hypoglycemic unawareness.
That's a really broad spectrum. What kind of symptoms might someone with diabetic neuropathy experience?
Varies greatly. Sensory, burning, numbness, tingling, stocking glove, pain, loss of sensation, risk for foot injury ulcers, foot deformities, weakness. Autonomic, dizziness, orthostatic hypotension, constipation, diarrhea, incontinence, dyspareunia, painful intercourse, impotence, hypoglycemic unawareness, nausea, vomiting, yearly fullness, gastroparesis,
Management.
early prevention, glucose LP control. Careful foot care is absolutely essential. Inspection, hygiene, avoid injury. Pain relief meds, antidepressants, anticonvulsants, bladder training, estrogen lubricants for dyspareunia, erectile dysfunction treatments, surgical decompression for some focal neuropathies.
Finally, let's discuss specific considerations for someone with diabetes undergoing surgery.
Yeah.
How is their diabetes managed perioperatively?
Managing diabetes around surgery needs careful planning. Patient, surgeon, anesthesiologist, diabetes team coordinate.
Pre-op.
Check with provider about withholding oral meds insulin. Some long-acting oral agents stop 24-48 hours before. Metformin often stopped 48 hours before. Restart when kidney function normal post-op and tolerating oral intake. Most other oral agents held day of surgery.
Insulin adjustments.
Dose timing might be adjusted day of surgery or withheld if IV insulin planned. Monitor blood glucose closely pre-intra post-op. IV fluids, often with glucose, given to maintain hydration glucose.
Post-op.
While not eating normally, IV glucose regular insulin might continue until oral intake tolerated. Once eating, supplemental short-acting insulin given based on frequent glucose monitoring. Close monitoring for hyper and hypoglycemia throughout.
We have certainly taken a very deep dive into the endocrine system today, from the master pituitary gland all the way to the tiny parathyroids and, of course, the complexities of diabetes.
It's a truly fascinating and intricate system, isn't it? Plays such a vital role in our overall health and well-being. Understanding how it works and what can go wrong is so important.
Absolutely. We've covered a vast amount of information from the fundamental principles of hormone regulation, like that feedback loop,
Right.
to the specifics of numerous endocrine disorders, their diagnosis, and their management.
And as we've seen, nursing care is absolutely crucial in all aspects of endocrine health, from assessment and diagnostic support to implementing treatments and providing that essential education for individuals to manage their conditions effectively.
Yeah, that education piece seems huge. If any of the specific areas we've discussed today have sparked your curiosity, we really encourage you to delve deeper and explore them further. We hope this deep dive has provided you with a solid foundation for understanding the endocrine system and its importance.
It really is a testament to the delicate balance within our bodies, and how profoundly these tiny chemical messengers, hormones, can impact our health and lives. Quite amazing when you think about it.
It really is. And that brings us to the end of our deep dive into the endocrine system. Thank you for joining us.